Welcome, and thank you for attending this School Nurse Professional Development online training. This training will cover food allergies and is topic 5 in a 5-part series. Highmark Foundation, in collaboration with Penn State Pro Wellness, is pleased to offer this professional development opportunity for school nurses. Between fall 2015 and fall 2016, this collaborative effort has resulted in 5 online professional development trainings utilizing physician experts to address select topics identified by school nurses. The first 4 trainings dealing with dermatology, mental health, diabetes, and asthma and allergic rhinitis are available now. Please note, the information provided in this web series should not be used during any medical emergency for the diagnosis or treatment of any medical condition. A licensed medical professional should be consulted for diagnosis and treatment of any and all medical conditions. Please call 911 for all medical emergencies. Also note that links to other sites are provided for information only. They do not constitute endorsements of those other sites. My name is Pamela Witt, and I am a project coordinator for Penn State Pro Wellness. Joining me is Dr. Deborah Gentile. Dr. Gentile is currently Professor of Medicine at Temple University School of Medicine and Director of Clinical Research in the Division of Allergy, Asthma, and Immunology at Allegheny Health Network in Pittsburgh. She is past president of the Pennsylvania Allergy and Asthma Association and the Pittsburgh Allergy Society and a member of the American Academy of Allergy, Asthma, and Immunology and the American College of Allergy, Asthma, and Immunology. She is a member of the Healthy Air Collaborative and a board member of the American Lung Association of Western Pennsylvania and For Your Good Health, a local nonprofit that conducts asthma screens and sports camps for underserved children. She is on the editorial board of the Annals of Allergy, Asthma, and Immunology and performs grant reviews for the Department of Defense. And now just a bit of information about Penn State Pro Wellness. Pro Wellness is committed to educating and inspiring youth and their families to eat well, engage in regular physical activity, and become champions for bringing healthy choices to life. We aim to be the trusted resource for educational programming, collaborative partnerships, and proven interventions in over 400 schools, communities, and like-minded organizations. PRO, Prevention, Research, and Outreach. Examples of our work based on this acronym can be found on our website. Our website also has many resources, including the opportunity to sign up your school or community-based organization to be a healthy champion. One of the many ways we accomplish this is through our school-based Healthy Champions program. If you are not yet enrolled in our Healthy Champions program, we do hope you will consider enrollment. This program includes free resources like event planning guides and promotional templates, customized school champion reports, future funding priorities, so you'll hear about funding opportunities first, and tools and resources to host and promote 4 annual events promoting healthy meals, healthy snacks, and outdoor play. These events include Apple Crunch, Go for the Greens, Move It Outside, and Walk the School Day. Annual registration is open April through June for the following school year and is required in order to receive a welcome kit and web portal password in September. There is no limit on how many schools can enroll, so log on to our website to read more details about the program.
Hello, this is Dr. Deborah Gentile. I'm the Director of Allergy and Asthma Research in the Division of Allergy, Asthma, and Pulmonary Medicine at Allegheny Health Network. We're going to be reviewing management of food allergies in schools today. I do have several disclosures to make. I am a consultant and speaker for Greer and Allergens. I also have done speaking for Merck and Teva, and I serve as a consultant for Mylan. as well as a member of the Data Safety Monitoring Board for AstraZeneca. The objectives of today's program are to summarize food allergy prevalence, triggers, and review definitions that are pertinent to this diagnosis, to recognize symptoms of anaphylaxis, and to review the treatment plan of anaphylaxis. We're also going to go over how to prepare an anaphylaxis emergency care plan, or an anaphylaxis action plan, as some people call it. We're also going to explore the emotional impact of food allergy on school children, review priorities that have been set for managing food allergies in schools, and understand recommendations for reducing risk of exposure, and then talk about how to translate these guidelines into practice. We're going to start with just a few food allergy facts. Food allergies is a growing public health concern. It affects about 4 to 6% of U.S. children. And it's also associated with a 2 to 4 times risk of asthma and other allergic conditions. Unfortunately, the prevalence of food allergies has increased about 18% over the last decade. And food allergy is the most common cause of anaphylaxis in the community setting. Allergic food reactions can be life-threatening, and they also have far-reaching effects on the child and family that we'll discuss later on. Unfortunately, 16 to 18% of children with known food allergies have had reactions at school. So we do need schools to be ready to address the needs of these children. We're going to focus on ways that the school can help prevent exposure, recognize the signs and symptoms of anaphylaxis, and implement an effective emergency response plan. A lot of what we're going to review today is based on the FDA Food Safety Modernization Act of 2011. As part of this, they came up with voluntary guidelines for managing food allergies in the schools. This is a team approach that's going to involve the school nurses, school administrators, and teachers, as well as parents and the physician caring for the child, or other practice participants caring for the child. Basically, the parents are going to have an obligation to provide the school with medical documentation of the food allergy. We want to create and maintain an individual plan for food allergy management for each patient, and we want that to be valid for both school as well as extracurricular activities and field trips, and we'll walk through all these components later. We want to make sure there's systems set up for communication strategies between the school and EMS. We also want to have some strategies to reduce the risk of exposures, and then a plan to train and educate school personnel. One of the most important things we need to talk about is timely access to epinephrine when school nurses are not available, because that does happen in many of our school settings. And also, we're going to review prompt notification to parents. Again, these are the voluntary guidelines for managing food allergies, and there are some specific recommendations for practice. Again, we're going to ensure that the daily management of food allergies in individual children is implemented. We want to prepare for food allergy emergencies, and we also want to provide professional development of food allergies for staff members, and also educate children and families about food allergies. And again, create and maintain a healthy and safe educational environment for all children. So what is a food allergy? Basically, it's an adverse health effect arising from a specific immune response that occurs reproducibly on exposure to a given food. It can be severe and life-threatening, and we will review the signs and symptoms of that. It's important that we do distinguish this from other food-related conditions that may be serious, but not immediately life-threatening. For example, many patients can't tolerate dairy products because they're lactose intolerant. You'll see that's not an IgE-mediated response, and it certainly can make a patient sick, but it's not going to cause an immediate life-threatening emergency. Similarly, patients with celiac disease do have an autoimmune problem that's underlying their gluten sensitivity, but it's not a specific IgE-mediated mechanism. Those patients do need to avoid gluten in their diet but aren't at risk of a severe allergic reaction if they eat it. On the other hand, it can cause long-term problems. There's several foods that account for the majority of reactions, and I see this day in and day out in practice. These foods are as follows: milk, egg, fish, shellfish, wheat, soy, peanuts, and tree nuts. This just reviews what anaphylaxis is. Basically, in a patient who has IgE or a food-mediated allergy, they have IgE floating in their immune system, in their circulatory system. It can even be in their mast cells of their skin and airways. And if they're exposed to that food allergen, these IgE antibodies actually alert the immune cells to release powerful substances, including histamine. And the release of these substances are what cause the life-threatening symptoms of anaphylaxis. We're going to review briefly some of the symptoms of food allergy. Symptoms can be multi-system, and we're going to go through each one in detail. First of all, you can have mucous membrane symptoms. This typically presents as red, watery eyes, or swollen lips, tongue, or eyes. Skin can be affected. You often will see itchiness, flushing, rash, or even hives. Gastrointestinal symptoms include nausea, pain, cramping, vomiting, as well as diarrhea. Upper respiratory symptoms can include congestion, sneezing, the development of a hoarse voice, difficulty swallowing, a dry cough, and numbness around the mouth. Lower respiratory symptoms can include deep cough, wheezing, shortness of breath or difficulty breathing, or chest tightness. Cardiovascular symptoms can include pale or blue skin, a weak pulse, dizziness or fainting, confusion or shock, hypotension, or even loss of consciousness. Additionally, patients can sometimes have mental or emotional symptoms. Many of them will describe a feeling of a sense of impending doom. Something terrible is about to happen. In children, you may also see irritability, change in alertness, mood changes, or even confusion. Children are going to articulate this differently. Certainly, if you're in a middle school or a high school, the child may be able to articulate in the words that we're trained as physicians and nurses to understand in medical practice. Some of the younger children in elementary school and even preschool may come out and tell you different things. So some of these things are very commonly, these are some of the things that are commonly described by children having a food allergy reaction. They'll describe it as something poking them in the tongue. They'll tell you that their tongue or mouth is itchy and burning. It'll often be described as feeling like hair is on their tongue or their mouth feels funny. They'll describe something being stuck in their throat or tell you the tongue feels heavy or full. They also might describe it as lips feeling tight and full. Many of them will report itching or a bug-like feeling in their ears. They'll say something feels thick in their throat, like it's sticky, or they might even say like a bump or a lump in the back of their throat or tongue. The timing and severity of anaphylaxis is important as well. The signs and symptoms usually manifest within minutes up to 1 to 2 hours after exposure. In rare cases, we do see it occur later, sometimes 4 to 5 or even a few hours later than that. But in typical settings, it's within minutes to 1 to 2 hours. Unfortunately, the severity of anaphylaxis is difficult to predict and it can vary. It's based on the individual's sensitivity, how much IgE they have to this particular allergen, as well as the type and the amount of exposure. Also, rate of absorption is important. If they've ingested it, they're going to have faster absorption on an empty stomach or if they're exercising. Also, if there's coexisting conditions such as asthma, you're going to see as we walk through this that asthma increases the risk of a severe reaction. The bottom line is you can't predict what's going to happen when anaphylaxis begins, so you need to respond quickly to it. Unfortunately, about a third of the children with food allergies also have asthma, and it's very important that you take home today that asthma increases the risk of severe or fatal reactions. It also increases the risk of emergency department visits and hospitalizations. Schools must really take into consideration the asthma risk when developing plans for managing food allergies. Anaphylaxis is a severe allergic reaction. It has a rapid onset and it may cause death. It's important to remember not all allergic reactions develop into anaphylaxis. However, it can be confusing since early signs of anaphylaxis resemble a mild reaction. Again, it's very difficult for us to predict who's going to progress, and that's why we take this very seriously and recommend close monitoring and possible treatment for anaphylaxis if we're concerned. There are fatal food reactions reported, and it's important to recognize that delayed epinephrine administration is the most significant risk factor associated with the fatal outcomes. Children in particular tolerate epinephrine very well. Obviously, if someone has an underlying heart condition, they may have trouble tolerating epinephrine. But in most cases, pediatric patients who are otherwise healthy can tolerate it. And we typically recommend erring on the side of administration versus holding and waiting and watching. Again, the studies have shown time and again it's the delayed administration that leads to the fatal reactions. No one's going to criticize anyone for administering epinephrine. The issue is going to come up if it's not administered quickly. So if there's any doubt, if it enters your mind, a recommendation is to go ahead and administer it. Also, a prior history of anaphylaxis does increase the risk of having another repeat serious reaction. Again, the fatal food allergy reactions, there are several risk factors identified. I can't stress enough delayed epinephrine administration. If you think about giving epi, you should probably do it. There's little harm to be done by giving it. And you will actually save a patient's life. On the other hand, if you delay administration, the situation could progress and get out of hand, and late administration could be a bit too late and contribute to death. We shouldn't rely on oral antihistamines alone at all. There is no data to suggest that they have any efficacy in anaphylaxis. It's not appropriate to just give an oral antihistamine if a patient's having anaphylaxis. You always need to give the epinephrine. Also, if there's simultaneous consumption of alcohol and food allergens, typically we won't see that in a school setting, but that's a well-identified risk factor for fatal food allergy reactions. There again are groups at higher risk. We know adolescents and young adults are at higher risk. They tend to be more cavalier and will be more likely to try foods that they may know they have a problem with. They have a sense of being invincible, so you'll see them taking more risk. The other thing that happens is they typically won't have access to an auto-injectable epinephrine device because, again, they think they're invincible, so they won't necessarily have it with them all the time. When I see these patients, I spend a lot of time talking to them about it and the potential severity of anaphylaxis and even the risk of death with anaphylaxis. Again, this is typical risk-taking behavior in this age group, and we know it happens, so we try to spend extra time with them on it. Anyone who's a child with a known food allergy is at a higher risk, obviously. Anyone who has a prior history of anaphylaxis. And again, those with asthma, particularly those with poorly controlled asthma. So if you have a patient who is using albuterol several times per day routinely, meaning that they're not controlled with their asthma, and they also have food allergies and come in contact with that allergen, they're much more likely to have a fatal reaction than if they had had well-controlled asthma. Timing of symptoms. Again, anaphylaxis usually occurs within minutes to several hours after exposure. Death can occur within 30 minutes to 2 hours, and it's typically from cardiorespiratory compromise. Unfortunately, by the time symptoms are recognized, the patient may already be in full-blown anaphylaxis. And many fatal reactions don't follow a predictable pattern. You know, for instance, we don't know, oh, the first thing that happens is you feel a little bit itchy, and then 10 minutes later you're going to feel a filling in your throat, and then 10 minutes later this is going to happen. It's unpredictable. It may appear that they're just having isolated nasal symptoms for a few minutes or slight itching, and then it can just snowball and get out of control with the onset of multi-system symptoms, difficulty breathing, cardiorespiratory collapse. So it's very important to not want to sit and watch to see what happens, to see if it progresses. It's important to act quickly. Some patients will have a biphasic reaction. This happens about 20% of the time. So what happens is if they had an anaphylactic reaction, those immune cells that are upregulated immediately start to generate new chemicals, and they're released about 4 to 8 hours later. And that's typically why we recommend watching these patients for several hours in the emergency room before determining if they should be released to home or admitted. Again, about 20% of patients will have this biphasic reaction that occurs about 4 to 8 hours later. And it can occur even if the initial symptoms totally resolve. The patient may look totally fine. You're watching them, you think they're going to be going home, and then they can quickly go downhill again. And this is why you want to, even if you look like the situation is under control in the school setting, if you've given epi and an antihistamine and they've normalized, they still need to be transported by EMS to an emergency department because there is a risk of this biphasic reaction. Again, they have to be monitored closely and evaluated promptly, so you want to get them into an emergency care setting. Treatment of anaphylaxis. Unfortunately, we right now don't have any treatments to prevent or cure food allergies and anaphylaxis. The FDA has fast-tracked some experimental products for testing to help alleviate peanut allergy, and they're in phase 3 testing right now. And we may have those products available in the next few years, but we're not even certain they're going to cure the disease or prevent it. We do think it may decrease the severity of it. But right now we don't have those, so that's important to remember. Really, the only thing we can do at this point to prevent a reaction is to avoid the food allergen, and that we all know that that's not always easy or even possible. And that's why we really stress the need for early and quick recognition of symptoms as well as treatment. We're going to talk a bit about epinephrine. It's a naturally produced chemical in the body. It's also known as adrenaline. When we give it by injection, it rapidly improves the breathing, increases the heart rate, and reduces swelling associated with anaphylaxis. Typically, you know it is available by auto-injector. It's quick acting but not long lasting. It can wear off after 20 minutes or so, and that's why you'll often see it being packaged now in packs of 2, so that if you're further out than 20 minutes for EMS to arrive, if you need to give a second dose, you have it. It's very important that if you give epinephrine, you please call 911 to transport to emergency department. Again, the medication can wear off, in a matter of several minutes, and you will be back in the same situation. Even if it does resolve initially, you can have a percentage of patients having that biphasic reaction several hours later. So you definitely want to invoke EMS, call 911, have the patient transported to the emergency department for further treatment and observation. There's also, we're not going to spend a lot of time on this today, but there are other allergens that may require use of epinephrine that can sometimes be encountered in the school setting. It's unlikely you're going to see patients who have drug allergies being exposed to drugs in the school setting, but patients who are allergic to penicillin or aspirin or other medicines could have risk. It does sometimes come up with children who are allergic to bee stings. yellow jackets, wasp, hornets, and fire ants. Basically, if they're stung, they have a risk of anaphylaxis as well because they have IgE against these venoms. And they pretty much follow the same type of plan. We teach these patients how to avoid bee sting exposures. Basically, you want to wear neutral colored clothing, not wear any strong scents. We often tell them don't dress or smell like a flower. You need to be careful with open drinks outside. Sometimes insects can get in them and you take a sip and the next thing you know the patient's having an insect bite in their mouth and having anaphylaxis. This comes up sometimes on playgrounds, this issue, and then it can sometimes come up on field trips. So these patients who are bee venom allergic will actually have action plans similar to food allergy patients on what to look for the signs and symptoms of anaphylaxis in the treatment. Regardless of whether the anaphylaxis is caused by a food or a drug or bee venom, the response is pretty much the same. You really look for the signs and symptoms of anaphylaxis, and if they're there, you give the auto-injectable epinephrine and basically implement the EMS system. In the southern states, they have issues with fire ants. We typically don't have that issue up here, although I have cared for a few patients who spend time down in the south and are allergic, and so when they're up here part of the year, they do get treatment for that problem. We do see some problems with latex, gloves, balloons, as well as other things that may be made of latex, and latex is known to cause anaphylaxis. And again, the treatment is the same, as for the food allergies. So there's some treatment decisions to be made when you're using epinephrine. A lot of the guidelines that have been developed, to date really focus on the healthcare setting. What do I, as a physician in my office, do? What does the emergency department do? And we really emphasize monitoring and proper treatment. There are not a lot of guidelines out there for, the school nurses, and really that's what part of this program is about today, to try to get everyone on board with this. The treatment decisions are typically made based on the progression or increased severity of symptoms and risk factors. Again, you have to know the patient's history. Do they have asthma? Is it poorly controlled? Have they had history of anaphylaxis to other things? Again, the guidelines favor quick and early use of epinephrine as soon as mild symptoms appear in high-risk children. And we're going to walk through specific situations when you do want to give epinephrine. I can't stress enough that no one's ever going to fault you for giving epinephrine. It can be life-saving, and the fatalities are very much attributed to delays in administration of epinephrine. So there are a lot of treatment decisions in the school. Public schools are required to have school physicians and school nurses, and they do use clinical guidelines. Unfortunately, many schools don't always have clinical staff on site. This is the reality. The staff person on site needs to be trained to call 911 immediately. We want staff, if they're trained on recognition of anaphylaxis and administration of epinephrine, we want them to be able to administer it at the first sign of an allergic reaction. And we want them to be able to ensure that the child is transported without delay in an emergency vehicle to the nearest emergency department. So there's clear-cut guidelines to follow here. And we recognize many times it's not a physician or a nurse that has to implement this. There's components of an anaphylaxis emergency care plan. This is typically provided by the patient's primary care provider, whether it's a physician, a nurse practitioner, or a physician assistant. Many schools have adopted this type of a program. They'll typically have the name, date of birth, and the weight of the child. We typically spell out what the food allergies are. We typically spell out right up front if there is a history of asthma or not, and what asthma medications are routinely administered. Most of the schools I've worked with also have a photo identification on this care plan so that people can immediately recognize the student is indeed this person. And then it actually walks through the symptoms from each of the organ systems that we talked about. and list the medications and doses that you would give for epinephrine, as well as antihistamines or breathing medications such as albuterol if they're needed. And it also lists emergency contacts so that the school personnel can, communicate effectively with the parents about what is going on. And typically it also lists the emergency contact for the primary care provider so that they can interact with them if necessary. But this is very much trying to be adopted as a standard. It makes the process very streamlined. Everyone has the same information. We tend to follow a protocol on it to make it as easy as possible. So basically what we want to do now is walk through the emergency care plan that's typically on one of these. For mild symptoms, so this would include things like nasal itching, runny nose or sneezing, mouth itching, if a patient's reporting just a few hives or mild itching, if they have some mild nausea or discomfort only. These are the only things considered mild symptoms. If there's any mild symptoms from more than one system area, you definitely give epinephrine. You could quickly have the situation get out of hand if you delay. Mild symptoms in more than one area, you want to go ahead and give epinephrine. If the patient comes in and they just have a little bit of nose itching or sneezing with nothing else going on, you do want to observe them for a period of time. And if nothing else progresses, you're okay, but if something else starts to progress, they start to break out in hives, or if they start to complain of belly pain, you definitely are in a situation where you're going to give epinephrine. So the bottom line here is for mild symptoms from more than one system area, you go ahead and give epi. Now, what do you do if there's mild symptoms from a single system area? You can give antihistamines if they're ordered by a healthcare provider. You want to stay with that patient and alert their emergency contacts, and you want to watch closely for changes. If the symptoms are worsening in severity to more than mild, what was described on the previous slide, or they're involving more than one system, again, for example, nasal symptoms as well as GI symptoms, you go ahead and give the epinephrine. The only time you're really going to be watching a patient is there's mild symptoms from one single system. Now, if a patient comes and they already have had the exposure and they have any severe symptoms, and we're going to walk through each of these because they're very important to recognize. Lung-wise, if they have shortness of breath, wheezing, or repetitive cough. Cardiovascular, if they're pale, bluish tinted, if they're fainting, have a weak pulse or are dizzy. Throat, if their throat is tight, if they have hoarseness, any trouble breathing or swallowing. Mouth, if they have significant swelling of the tongue or lips. Skin, if they have many hives over the body or widespread redness or flushing. Gut, repetitive vomiting, severe diarrhea, severe abdominal pain. And again, there's other things. Some of them may have anxiety or confusion, or they'll have that sense of doom, the feeling that something bad is about to happen. These are all considered severe symptoms of anaphylaxis, and you do not need any combination of these. You need just one of these severe symptoms to have an indication to administer epinephrine. So basically, if there are any severe symptoms or a combination of the severe symptoms from different body areas, again, you just need any single one. You want to inject the epinephrine immediately. Call 911. Consider antihistamines if they're prescribed. Consider bronchodilators such as albuterol if they're prescribed. And that should all be on their action plan. You want to lay the child flat and lift their legs because that will help with the anaphylactic shock. The only caveat to that is if they're vomiting, we do prefer you lie them on the side, and a lot of times if they're having difficulty breathing, they have better air entry if they're sitting up. But if they appear to be more hypotensive, where they're lightheaded or actually passing out, you do want to lay them flat and lift their legs. And then certainly allergy emergency contacts. And you will see in many cases, once you've administered epinephrine, these symptoms will resolve. Regardless of whether they resolve or not, the patient must go to the emergency room. and they need to remain there for at least 4 hours because of that potential for a biphasic reaction. So even if you've given the patient epinephrine, their parents arrive on the scene and think they're safe to go home, it's really important that they go by EMS to the emergency room because they could recur. The symptoms could recur, and we could be in a fatal situation. So what else is on this anaphylaxis emergency care plan? Again, we walk through the medication and the doses. The epinephrine is typically listed, both its brand name as well as what dose. For the younger children of a lower weight, we'll typically use the 0.15 milligram dose. For the older and heavier children, as well as adults, we use the 0.3 milligram dose IM. And that should be clearly spelled out on the patient's action plan. The antihistamine, if the doctor has recommended an antihistamine, should be described by both brand as well as what the dose is. And typically that's administered orally. And then certainly if they have asthma, the doctor or the primary care provider should be ordering albuterol via nebulization or a inhaled device. So these are typically your mainstay medicines. Again, the most important one and the one you don't want to delay is epinephrine. And then certainly if the physician or a healthcare provider has given you guidelines for dosing the other medications, you can go ahead and give those. Now, there's different directions for some of the different epinephrine auto-injectors, and this is a point of flux right now. Most of us are familiar with the EpiPen, but there is also another product on the market called the Adrenaclick right now. And the EpiPen will also shortly be launching a generic version of their product. It should be exactly similar to the brand name product. But they all do work very similarly, but they are not exactly the same. If you have an Adrenaclick versus an EpiPen, there's some slight differences. So you do want to make sure you're aware of all of those, and they're typically spelled out in the product inserts. But basically the common components, you want to remove the auto-injector from the plastic carrying case, pull off the blue safety release cap. You're going to swing and firmly push the orange tip against the mid-outer thigh. You don't have to remove clothing. It will go through clothing. And then you're going to hold for approximately 3 seconds, and then remove the auto-injector device from that area and then massage the area for approximately 10 seconds. Again, you want to practice this. The auto-injector pens typically come with a practice device. In the office, we tend to train the older patients as well as their families on it. Many of the manufacturers of these devices have DVDs available that we can help distribute if needed as well to other caregivers and even schools if necessary. But you really want to make sure you know how to do this. Again, you remove the auto-injector from the case, pull off the blue safety release cap, swing and firmly push the tip against the mid-outer thigh, hold for about 3 seconds, go ahead and remove the auto-injector and then massage the area for 10 seconds. There's also room on the emergency care plan for other directions and information. If the physician or the provider feels the child is old enough and if the school allows it, the provider can indicate if the patient is able to self-carry and self-administer epinephrine. Most of the plans I have seen first ask the provider if they feel the patient's able to do that. And then many of them also have the school nurse confirm that the child can do it before the school will sign off on it. Obviously the younger children aren't going to be able to do this. Every time we see the families, we go over this process with them. And, eventually when the child's old enough, we do start to teach them to self-administer. But it's not just a clear-cut, age. It's really a maturation step. And some of it's based on the individual child's personality and their response to emergencies. So it's really a group decision when this can occur. You want to always treat the person before calling emergency contact. That person is there. Anaphylaxis can get out of hand very quickly in a matter of seconds or minutes. The important thing is to always treat the patient with the epinephrine. and you just want to stop the progression of this before it can get out of hand. I just want to spend a few minutes on this. The emotional impact of food allergy is significant. For parents of a child with food allergy, these parents are constant fear of a reaction. Some of them can, some of them may come across as being over the top and overly concerned, but they deal with the fact every day that their child come in contact with an allergen that could kill them. I think it causes a lot of chronic stress in them. They feel they need to be constantly watching the child and preventing reactions, and if there's an accidental exposure, they often think it's their fault. So they're very concerned about what's going to happen to their child and whether they're doing all the right things. It has a significant impact on family dynamics. For the child with a food allergy, they're often very afraid and they can be stressed as well. A lot of their coping strategies limit social interactions and other activities. Some of these kids, they don't want to go over to other classmates to play. They may not get invited to parties because of food allergens. They may be afraid to participate in social activities. So a lot of them do feel socially isolated, and they have a lot of emotional burdens. And unfortunately, sometimes they can be targets of teasing and bullying, and I know that's been an issue in schools overall, that the schools are really trying to tackle that. But sometimes they can, have anxiety and stress, caused by that teasing and bullying. We try to take an approach with our programs here that we educate everyone. Even if you yourself don't have a food allergy, one of your buddies might. So we try to teach, all the children about what the problem is and how we treat it and go from there. But it's very important to remember that this does affect the overall emotional impact of the child, and it often impacts family dynamics because of the constant fear of an adverse exposure. So food allergy management in schools, it's very important to use a coordinated approach. It has to be based on effective partnerships. Again, this partnership includes the child or the parent, the allergist or other provider, and then certainly the school staff is key. We want to provide clear leadership to guide the planning and ensure implementation of the food allergy management plans and practices. We need administrators such as principals to be on board, as well as school nurses and doctors. And then really the goal is to develop and implement a comprehensive plan for managing food allergies. And we're going to spend quite a bit of time now talking about this. There are priorities for managing food allergies. First of all, we want to ensure the daily management of food allergies for each individual child with a problem. So in that regard, it's very important to identify the children up front with food allergies, and then for each of them to develop a plan to manage and reduce the risk of their reactions, individually. And then we want to, over time, help students manage their own food allergies. As they get older, they're going to learn what to do. One of the top priorities for managing food allergies is preparing for food allergy emergencies. And I tell all my families that, we're as careful as we can be, we're as prepared as we can be. You do all the right things, but occasionally an accidental exposure happens, and we want everyone to be trained on what to do if there is a reaction. So we need to make sure we're prepared for any food allergy emergencies. We want to set up communication systems that are easy to use. We want to make sure the school staff can get access to the epinephrine auto-injectors quickly and easily. We want to make sure epinephrine is used when needed and that someone immediately contacts EMS. And we want to identify the role of each staff member in an emergency. We also want to be prepared for food allergy reactions in children without a prior history of food allergies. And we want to document the response to a food allergy emergency. So we'll spend time on each of these. There are stock supplies of epinephrine in some states, and Pennsylvania does allow this. Some state laws, including Pennsylvania, allow for prescribing stock supply of non-patient specific epinephrine auto-injectors in schools, and I have been asked myself by some schools to provide this. And what these are backup supplies for children with known food allergies or a supply for a child who might experience anaphylaxis for the first episode. So the state law in Pennsylvania does allow for it. It's going to be up to the district whether they, pursue this or not. And the manufacturer of one of the brand name products does provide these to the schools free of charge through a national program if the schools are interested. So I think that's an important point, especially with the recent media attention we've seen with the cost of auto-injector epinephrine pens, just being very high priced and difficult for families to have them in multiple locations. And the nice thing about the program is if the school dispenses, if the school actually uses one of the devices, it will get replaced by the company free of charge. So there are steps to take within 24 hours of a food allergy reaction. We already walked through what the signs and symptoms are, what's mild, what can be watched, only mild symptoms in one organ, when you need to give epi and implement EMS. But what do you do in the later stages? You definitely want to call the parent within 24 hours to follow up on the student, what their condition is. You want to review the episode with the parent and student, identify what the allergen was, the route of exposure, signs and symptoms, review what the actions were taken. Things are always a learning process. Discuss positive and negative outcomes, and discuss any needed revision to care plans. This is something that goes on in practice every day. Sometimes things need to be fine-tuned. This is not finger-pointing in any way. There's always good things that have happened and things that could be improved, and it's not to really blame anyone. It's to really try to take what could be improved and make it actually happen. So it's important for the review to do the review process to learn these things. You want to discuss with both the family and the school the role they each have to improve outcomes. If you need the parent to replace the epinephrine auto-injector, please ask them to do so. And then the parent should also be instructed to follow up with their primary health care provider. But again, this is just to make sure did things go the way we wanted them to? Was this a smooth transition? Did we identify an unexpected bump in the road that we need to plan for better in the future? And this goes on every day. This goes on in my office, every day, and goes on in every medical setting. The priorities for managing food allergies. You also want to provide professional development on food allergies for staff. You want to provide general training for all the staff, and then in-depth training for staff who have frequent contact with children with food allergies. And then you want to give specialized training for staff who are responsible for managing the health of children with food allergies on a daily basis. So that typically comes down to the school nurses and doctors if they're available in the schools. Again, the priorities for managing food allergies, you want to educate children and family members about their disease as well. You also want to create and maintain a healthy and safe educational environment. The kids are there to learn. We want to do everything we can to make them safe and feel comfortable so that their learning and their learning experience is enhanced. So to do this, we want to create an environment that is safe as possible from exposure to food allergens, develop food handling policies and procedures to prevent food allergens from unintentionally contacting another food, called cross-contamination. If outside groups are using the school facilities, we want to make them aware of the food allergy policies in the school as well as the rules that they need to use when they're at the school facilities. And basically, we want to do all this work while creating a positive psychosocial climate. We don't want to make the patients with the food allergies feel like they're penalizing everyone else involved in the process. There are specific recommendations for reducing risk of exposures. We're going to walk through these. In the classroom setting, you want to consider designated allergy-friendly seating. You do want to avoid the use of identified allergens in classroom. I had one patient one time who in elementary school art class, they were making bird feeders, and they actually were using nuts and sunflower seeds and peanut in their homemade bird feeders, and the patient experienced their first episode of anaphylaxis. So we really want to try to avoid those, major food groups that we know are associated with food allergies in classroom settings. You do want to avoid ordering any food from restaurants in the classroom setting, and you want to have rapid access to epinephrine auto-injectors and train staff how to use them. The cafeteria can be a big trigger spot. You want to consider designated allergy-friendly seating. It's basically open to any child who's not eating foods, who is eating foods that are free of identified allergens. So you want to, instead of taking the kids who have peanut allergy and making them sit at a separate table, you want to have allergy-friendly seating where it's open. As long as the child doesn't have that allergen, they can come in. It doesn't matter if they're peanut allergic or tree nut allergic, just so they don't have an allergenic food, they're able to go into that zone. You want to have rapid access to epinephrine auto-injectors and train staff how to use them. Transportation. You want to train transportation staff on how to respond to food allergy emergencies. Also have rapid access to epinephrine auto-injectors and train staff how to use them. This is going to vary by school district as well. Again, remember, everything we're talking about today is voluntary guidelines that have been put into play. Children could have exposures on school buses or school vans, and it's very important that those staff recognize the emergency, and depending on what the district wants to do as an approach, train the staff on epinephrine auto-injectors. Field trips and extracurricular activities come up a lot. We really don't want to take these children and limit their activities. We want them to be able to participate in as much as they can. So you want to find out if the location is safe for the children with food allergies. We want to make sure the events are consistent with food allergy policies. We want to not exclude the children with food allergies. You do want to invite but not require the parents of food allergic children to attend these events. And then you always have to have rapid access to epinephrine auto-injectors and train the staff how to use them. Many of the action plans I've been filling out for anaphylaxis for schools for individual children are now listing this as a separate section, what needs to be done on the field trip. Again, it's basically avoiding the allergens, limiting the risk of exposure, and then having rapid access to the epinephrine. But many of the schools are adopting this approach too. They're recognizing that we want to include these children on field trips and extracurricular activities, and they're trying to be very proactive about it. Gym class and recess. You don't want to, again, exclude children with food allergies, and you still want to have that rapid access to epinephrine auto-injectors and train staff how to use them. Okay, meals and snacks in the classroom. You always want to use non-food incentives. You can't go wrong with the sticker approach. Foods really shouldn't be used as a reward. We're certainly worried about obesity as well as food allergies, so we don't want to do that. We want to start to help students with food allergies learn to read labels. We want to think about cross-contamination and how to prevent it. You do want to be supportive of parents who wish to provide safe snacks. And then you always want to encourage the children to wash hands before or after handling or consuming food. That's actually a good pathway to get into. Before everyone eats and after they're done eating, let's wash hands real well. And then you want to include information about specific children with food allergies to substitute teachers. There's a lot of burden in the schools, and substitute teachers can come in and not know anything, so it's just important that this information be carried over. It's always better to have everyone educated and know what the potentials are to happen here than to, not inform everyone. And that's, again, is where that action plan comes into play, particularly whenever they involve the identification picture. It helps make people who may not know the children as well and don't recognize them necessarily by name. It will actually help them quickly identify them. The cafeteria, you want to try to make reasonable meal accommodations once you receive the doctor's orders. You do want to create standard procedures for identifying these children with food allergies. Again, this is where the photos and non-public view come into play. You have your FERPA privacy regulations as well, so you're not going to be wanting to post these photos in public areas, but you do want the staff to be able to see them. Again, you want to designate allergen-safe food preparation areas. You want to provide copies in advance of the menu to parents so they can use in their day-to-day planning. And then you always have to be ready to share food labels or ingredients. Know if there's any potential exposures. Meals and snacks for transportation. We think it's safe. The safest bet is to not allow any food to be eaten on buses or school vans unless the child has a special need such as diabetes. This is a difficult situation. There's often just one adult on the bus, and they're focused on driving the bus and making sure the children are safe that way. The best bet is to really just not allow any food on the buses unless there's a medical need for it. And again, that hand washing is important because it'll decrease the likelihood of carrying allergens over. So you want the kids to wash hands before and after handling or consuming food. Field trips, extracurricular activities. You have to identify these special needs before the field trip or event. You want to make sure meals and snacks are appropriately packaged to prevent any cross-contamination, and again, that good hand washing before and after eating by children. Again, we really don't necessarily have to have a snack with every ball practice. That's become popular over the years, but there's really not a necessity for that. So if possible, we try to discourage it. That way no one's left out. You're not going to have to worry about this cross-contamination. Again, gym class and recess, you want to encourage the children to wash their hands before and after handling or consuming food. They typically shouldn't be eating in gym class. I think in some recesses they may, but you do want to do that good hand washing. Now, there's a lot of work to putting these voluntary guidelines into practice, and they take time and they take the involvement of a lot of people. You always have to have the school district policy support. There's going to be specific guidelines that were put forth for school board, superintendent, health service director, student support services director, and food service director. We're not going to have time today to go through each and every one of these, but we're going to focus on the healthcare providers in the school setting and those type of personnel who come in contact with the children frequently. But the voluntary guidelines do go through and list specific guidelines for each of these roles. The actions of school administrators and staff, this includes principals, school nurses, school doctors, any healthcare assistants or aides, teachers, school food service managers and staff, school counselors and other mental health staff, bus drivers and transportation staff, and facilities and maintenance staff. A lot of people involved that could, potentially help prevent reactions and potentially save someone's life by giving epinephrine if needed. So there are specific actions for each of them to follow. And again, it's voluntary what you adopt and what you don't adopt, but they've given you a very good framework to start. Obviously, we're going to spend most of our time with the school nurses because that's what this program focuses on. A lot of burden does go to the nurses. They do participate in a very coordinated approach to managing food allergies. Everything the school nurses manage is coordinated care between them, the physician or healthcare provider, as well as the family. They're pretty much bearing the burden for supervising the daily management of food allergies for each individual student. And they are the ones that are prepared for and respond in most cases to the food allergy emergencies. In many places, they'll provide professional development for the other staff on food allergies, and they often do provide a source of food allergy education to students as well as parents. And in general, the school nurses are focused on creating and maintaining a healthy and safe school environment. So they really have become the role model in the schools, and they very much are on the front line here. And their involvement is very important in this. There are federal laws and regulations concerning food allergies. We're not going to walk through each of these, but just an overview. Section 504 of the Rehabilitation Act and the American with Disabilities Act does designate that food allergies can be considered a disability. So I do have some patients with these plans in place in the schools. There are guidelines and laws from the U.S. Department of Agricultural School Child Nutrition Program, where if a child's allergic to one food, other foods need to be substituted. And then there's Individuals with Disabilities Education Act. And then we had mentioned it before, Families, Educational Rights, and Privacy Acts can play a role too. But there are a lot of regulations in the school setting, and these guidelines were put together, to help bridge these different things and to make sure everything was being legal. Everything was legal. And with that, I'm going to go ahead and conclude. I want to end by just saying that the most important thing to remember here is that if a patient presents and they have any severe symptoms of anaphylaxis, you want to go ahead and administer the auto-injectable epinephrine. If they have only one if they only have one organ system that's mildly affected, you can wait and watch, but if there's more than one organ system affected with mild symptoms, you definitely want to administer the epinephrine and activate EMS. The fatalities related to food allergy have been linked to delayed administration of epinephrine. If you're in doubt, your best bet is to always go ahead and administer this life-saving medication. And then the other point to keep in mind is that the children with severe asthma are at a heightened risk for anaphylaxis if they also have food allergies. So if they do have asthma, you want to make sure that you're aware of it and you understand their severity and control level, and they do have emergency medications available. So I thank everyone for their attention, and that concludes this program.
Dr. Gentile, thank you for lending your expertise on food allergies. And thank you, our listeners, for participating with this online training. If you have any questions regarding this training or any future offerings, please contact Penn State Pro Wellness. Thank you again.